Thanks for talking to us today, Dr. Ainhoa Costas Chavarri. You've been working in Rwanda for the past a couple years?
Almost 3 years now, yes.
Okay. Tell us a bit about how you got that opportunity, how you're funded, what organization you're working for.
I knew when I was in residency, general surgery residency, that I wanted to do some type of international work. So as I was finishing my fellowship, I decided to look at opportunities of how I could pursue my dream. And I started looking at things like Doctors Without Borders, but I wanted something a little bit more long term. And I had a friend of mine who was in Boston, and he told me about the Paul Farmer Global Surgery Fellowship. So I applied and I was accepted as a clinical fellow. So I did that for 2 years, and most of my work was based in Haiti. So I was going back and forth from Boston to Haiti for about 2 years. And during my time in Haiti, I found out about this new program that was coming up in Rwanda that was called the Human Resources for Health program in Rwanda. And that's where I am now.
Okay. So if somebody were considering a career in international surgery, where would be some places they might look around to find opportunities?
So there's not that many clearinghouses per se, but one good place that you could go to is the American College of Surgeons Operation Giving Back website. They have a nice list, and it's separated by opportunities for residents as well as for attending level surgeons. You could also try, for example, the NGO SOS, which stands for Surgeons Overseas. I believe they also have a list of opportunities as well.
Okay. So tell me about your case mix there. Is it different from the cases you did in your training in the U.S.?
So it's a little bit different, yes. So I do mostly general surgery, and I would describe it as being an old time or old school general surgeon. Basically, anything in the abdomen. And then I also do pediatric surgery as well because there's no pediatric surgeons in Rwanda. There's no burn surgeons, so we take care of the burn patients as well. There's no vascular surgeons, so if there's any vascular injuries, I have to manage those as well. So a little bit of everything and trauma as well.
So truly a general surgeon. What about
Yes.
just how patients present? Is there a difference in terms of disease stage or patterns of diseases or trauma that you see that's different?
Yeah, so a lot of the traumas here are based around motor vehicle collisions. There's a lot of motorcycles on the roads, so even though Rwanda has a policy that everyone has to wear a helmet, there's still a lot of accidents. So you'll see a lot of long bone fractures, extremity fractures. Aside from that, patients do tend to present at very delayed stages. There's not a lot of health education. Even education in general is quite low. So if it's not really bothering someone, they'll wait until they really have to go to the hospital.
That's got to be tough to see diseases that might have been better treated at an earlier time.
Yeah, definitely. So there's a component of the patient delay, but also a provider delay, because the way the health system is set up, patients have to go to either a health center or a district hospital first. And then if the physician there feels the need, they can get transferred to a referral hospital where most surgeries take place.
And tell me about staff and supplies in your hospital and your typical work week and how it's different because of those things.
So there's three major referral hospitals in Kigali. I'm in Kigali, the capital of Rwanda. The hospital that I work at is called the Rwanda Military Hospital. I like to describe it as being the equivalent of a VA in the US. It is a military hospital, but there's about 80% civilians that come into the hospital. So the staff, we're well staffed. However, the materials can come and go. A lot of times we have problems in the theater with electricity going out several times throughout a case. Water also can come and go throughout the day. Instruments, I don't have any special sets. I just have a general surgery set, a major set, and a minor set, and that's for just about everything. So things like that.
Wow. How about post-op care? Are there differences in how the patients recover? Are they in big open wards, or what's it like?
Yeah, so we have a one big general surgery open ward, and I'm always surprised at how well patients do because patients that in the U.S. would probably spend the night in the ICU go directly to the ward and just cared for by the nurses there, even big laparotomies for trauma. So it's impressive the work that the nurses can do. Um,
Is there such thing as an intensive care unit?
There is an intensive care unit, but it's quite expensive, so not all patients can afford it, and the beds are also quite limited, so we can't send as many patients there as we would like.
And you do a lot of breast care, I understand. How is the management of breast cancer different there than your experience in the U.S.?
I do. So even though I'm a general surgeon, there was such a huge need for breast care here that I started collaborating 2 years ago with the only oncologist in the country. So the two of us run a multidisciplinary weekly breast clinic. And we see patients from all over the country. We found that there's not a lot of education around breast care or breast self-exams. So our patients, unfortunately, they tend to present quite late, usually at the stage where they would be getting neoadjuvant chemotherapy first.
Wow. Um, you also see a high incidence of gastric cancer. Is that the case?
We do actually. I'm not sure why, but there's among the population, it seems to be known that there's certain areas in East Africa that have high rates of gastric cancer. So we're trying to do a couple studies to figure out why that is. It may be related to the high rates of H. pylori, but we're not quite sure.
And are these patients managed by surgery and neoadjuvant therapy?
So for our breast cancer patients, we're very lucky that Partners in Health has a cancer center in collaboration with the Dana-Farber Cancer Institute up in the city of Butaro, which is about a 2.5 hour drive away. So patients can go there to get their chemotherapy, and then they can come back to us for surgery. Unfortunately, the only surgery we can offer them here, because there's no radiation in the country, is a modified radical mastectomy.
How about for the gastric cancer patients?
For the gastric cancer as well, they can get some chemotherapy up at Butaro Hospital, and then we can offer them a gastrectomy as well. However, as you know, even in the U.S., the proper staging for gastric cancer can be difficult. Here, it's even more so because we don't have endoscopic ultrasound. All we have are CT scans, and they're not that great either. So a lot of times we find ourselves going in and just doing a palliative bypass.
Oh, sounds like interesting work. What's your
Yes,
favorite
thank
thing
you.
about working in Rwanda?
I think what I enjoy the most is I spend the vast majority of my time teaching Rwandese medical students and surgery residents. So for me, that really is the most gratifying, being able to take everything that I've learned in the U.S. And transferring it to them, and knowing that the next generations of surgeons here won't need anybody from the U.S. to come and teach them. They'll be able to do it themselves.
Very good. Well, thanks for talking to OnSurge today, Dr. Costas Chavarri.
Yes, thank you.
Bye-bye.
Bye.
Thanks for checking out the Op Report. Help us keep conversations alive on topics in general surgery. Check out more episodes of the Op Report and other OnSurge content here at YouTube. Find us at Facebook, follow us on Twitter, and find our homepage at onsurge.com. Join the conversation and tell us what topics you'd like to hear about and what people you'd like to hear from.